from Egypt, and today I'm going to share my clinical experience with you about bioceramics in daily practice. We have two major bioceramic products. Root ST is a pre-mixed bioceramic sealer that comes in a syringe form, while Root ST is a pre-mixed bioceramic putty that comes in a capsule form. Composition, both are composed of calcium aluminosilicate compound as a bioactive component, zirconium oxide as a radiopacifier, which does not cause any discoloration and thickening agent. Uses, of course, root ST, the bioceramic sealer, is used as a permanent root canal filling material in conjunction with gutta while root PT, the bioceramic putty, is used in vital bulb therapy, direct and indirect bulb capping, partial and complete bulbotomy, regeneration, revascularization as a retrofilling material in apical surgery, lateral and focal perforation repair, internal and external root resorption. Of course, nowadays there are so many studies that support the use of bioceramics, if anyone is interested. And here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealer. In this study, they compared and classified the hydraulic cements according to the percentage of the calcium silicate content in the composition. And they classified the hydraulic cements as follows, which is low charged, which is lower than 20% of calcium silicate content in the composition, medium charged, which is higher than 20 and lower than 40, higher charged, which is equal or higher than 40%. According to VERICOM's material safety data sheet, root ST contains from 50 to 60 calcium silicate content in the composition, which is considered the highest PC sealer in calcium silicate content worldwide. What is hydraulics? Simply, hydraulics is the injection of the bioceramic sealer into the root canal system, then applying your master concrete to the full working length, which act as a sealer, as a piston that pushes the sealer into any susceptible microanatomy. Is it powerful enough to fill the whole head root canal system to get a 3D obturation? Let's find out. Here is a lateral canal filled related to upper lateral incisor. Here is a lateral canal filled related to upper canine. Here are two lateral canals filled related to lower first premolar. Here are two lateral canals filled related to upper second premolar. Here is an isthmus area filled related to upper first premolar. Two lateral canals filled related to upper first premolar. Here is a lateral canal filled related to a lateral radiolucency. A lateral canal filled related to the medial root and the apical delta related to the distal root. Here is a lateral canal filled related to the medial root, and here is a 3-year recall, shows that the material still exists, did not washed out, did not resorb. Here is an isthmus area filled and a lateral canal filled with the sealer, and the 5-month recall shows healing and the lateral canal is still filled with the sealer. Here is a nice microanatomy filled with the sealer. Here is a lateral canal filled related to the palatal root of upper first molar. Here is a loop filled related to the mesiobuccal root of upper first molar, and here is a 3-year recall, shows healing, and the lateral canal is still filled with the sealer, plus the loop is still filled with the sealer. Upper central incisors has more than 40% incidence of accessory canal, and there is a variety of microanatomy in upper central incisors. When patency not achieved, what to do? Here is a type C lower second molar. I wasn't able to achieve patency, so I injected the sealer and added tapered auxiliaries. After I sealed off the gutta, I got two lateral exits filled with the sealer, as you can see, and here is 3 months recall after indirect composite restoration. In this case also, I wasn't able to achieve patency. After I injected the sealer, I got nice microanatomy filled with the sealer. In this case also, the distal root, I wasn't able to achieve patency. As you can see, I got a tortuous lateral exit filled with the sealer. It's quite nearly impossible to negotiate this lateral exit with the hand files. Here also, I wasn't able to achieve patency in the distal root. As you can see, the sealer flows through its correct path till the end. Here also, I wasn't able to achieve patency. After I injected the sealer, I got an abrupt 90-degree lateral exit filled with the sealer. Yes, we can do bypass the instrument from the other patent canal, as it's type 2 mesial root. Root ST will help you achieve the optimum apical seal in almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter, extremely curved roots, multi-planar curvature, S-shaped curvature in case of conservative shaping, these with external root resorption, compromised roots for strengthening, large apical lesions as it promotes healing. This canine was 32 millimeter length. Here is a multi-planar curvature combined by conservative shaping related to upper first molar. Multi-planar curvature combined by conservative shaping related to lower second molar. Multi-planar curvature combined by conservative shaping related to lower second molar. Extremely curved and long roots upper second molar. This is an upper second molar with tough and severe curvatures. As you can see, this is a master apical file. And here is the immediate post-obturation using the sealer and gutta-percha. It's quite easy. Inject your sealer, put your gutta-percha cones, sear off the gutta-percha, and you're done. Here's another X-ray view. Separated file retrieval. When we retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics as it bonds to dentin and act as a mono block. Here is after we injected the sealer, we got a furcal canal related to the furcal radiolucency filled with the sealer, and here is after 1 month after crown placement. As you can see, this case have a separated file plus a large radiolucency. A large radiolucency. After I retrieved the separated file, the canals were oozing exudate, and I had to finish the case in 1 visit. So I injected the sealer and finished the case in the same visit. And here is the 8 months recall shows complete healing, and the sealer still exists, did not washed out, did not resorb, which is a very tough test. The sealer can be easily washed out before its final setting. Here also, after we retrieved the separated file, we compensated the lost dentin using bioceramics. This is a retreatment case that went from simple to very difficult. During gutta-percha removal, I separated 5 instruments, and one of them goes beyond the distal apical foramen. I managed to retrieve all 5 instruments, and here is the immediate post-obturation. And this is the 1.5-year recall, shows complete healing, and the sealer still exists, did not washed out, did not resorb. Healing for large lesions, as you can see, this is a J-shaped radiolucency. After we did the treatment, this is a 2-year recall, shows almost complete healing. This is another retreatment case. Part of the sealer, some of the sealer went out of the apical foramen, and this is a 3 months recall, shows significant reduction in radiolucency size, and this is a 1-year recall, shows complete healing. The sealer still exists, did not washed out, did not resorb, did not prevent the healing. This case also, despite there is a separated file beyond the mesial root, there is complete healing after 6 months. Complete healing after 4 years, and the lateral canal is still filled with the sealer. This is an 8 months recall, shows complete healing of the furcal bone, the furcal radiolucency related to the furcal canal. 1.5-year recall shows almost complete healing. This is a 10 months recall, shows complete healing. This is a tough retreatment case. I did surgical and non-surgical retreatment. This is the immediate post-retreatment, surgically and non-surgically. And this is a 5 months recall, shows significant reduction in radiolucency size. This is another tough retreatment. This is the immediate post-retreatment. This is a 5 months recall, shows significant reduction in radiolucency size. This is another X-ray view. We leave the file outside. If it's any problem happened, we do surgical intervention, just remove the file. That's it. But all symptoms subsided. In cases of limited accessibility and limited mouth opening, this is a lower wisdom with nice internal anatomy, filled with the sealer. Long-term recalls. When we use a new material, we have to follow up and recall as much as we can the cases to see how the material will interact by the years. So this is a 7-year recall for a tough lower wisdom with the sealer still exists in the isthmus, did not wash out, did not resorb. This is another 7-year recall for the sealer related to lateral and upper canine. This is another 7-year recall for this tough calcified upper first molar. The sealer still exists. Anyone here practicing vital bulb therapy? Anyone here practicing vital bulb therapy? No one? No one at all? Okay. American Association of Endodontists position a statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from traumatic injuries, caries, or restorative procedures. Vital bulb therapy procedures have traditionally included indirect, direct bulb capping, partial and complete bulbotomy. What are you doing in trauma cases? Trauma cases, what are you doing? With exposed bulb. تعملوا ايه؟ direct bulb capping. تعملوا ايه؟ trauma cases. Root canal? You go for root canal bulbotomy. So you are doing vital bulb therapy. Correct? Number 1, we have 5 steps to move to get a successful vital bulb therapy case. Number 1, diagnostic considerations of vital bulb therapy. You should have sound diagnosis. لازم يكون عندك تشخيص سليم. The current AE diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible, or irreversible bulbitis. Number 2, caries management, complete caries removal. Any residual caries left behind will affect the prognosis. يعني اللي بيسيب كيريز ورايا الدكاتره هيحصل failure. حته بالعربي كده بسرعه يعني. Use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis, disinfection of the dentine bulb interface. Hemostasis can be achieved within 5 to 10 minutes either via direct passive irrigation or in a sodium hypochlorite soaked cotton pellet. تمسك السيرنج بتاعتك passive irrigation على الاكسبوجر سايت او البلبوتومي سايت or soaked cotton pellet with sodium hypochlorite in the exposure or the bulbotomy site. We can do both. Use of contemporary materials in vital bulb therapy. This is number 4. We use calcium silicate cements or bioceramics as it has improved barrier quality than calcium hydroxide. Number 5, immediate placement of a permanent restorative material. The advantages of the immediate restoration is the prevention of the micro leakage, protection of the biomaterial layer, reduction postoperative sensitivity and thermal conductivity. So you should do all 5 steps in one single visit. We don't do temporary restoration, we do final permanent restoration. The primary goal of vital bulb therapy procedures is the creation of optimal conditions for bulb tissue repair and preservation. Last paragraph in this part, a pre-treatment diagnosis of irreversible bulbitis is not necessarily an indication for bulbectomy, as more conservative treatment could be considered. What do they mean by this? This paragraph, please pay attention. What do they mean by this? They mean that we can do bulbotomy in cases diagnosed with irreversible bulbitis. Okay? صعبة دي. تعملوهاش صح؟ تعملوهاش دي. ماشي. هنشوفها دلوقتي. Where would be the different clinical applications? Direct, indirect bulbotomy. Here are the cases. We did direct bulb capping. As you can see, this is the capping material inside the bulb horn. After 4 years, the bulb horn returned intact again. There is a barrier was formed, and the tooth was completely asymptomatic, responds normal to cold with no any radiographic finding. Here is also a direct bulb capping, and here is the 1-year recall. Shows barrier formation. Tooth was completely asymptomatic, responds normally to cold with no any radiographic finding. This is, you know, how you got a successful vital bulb therapy case. Here also we did direct bulb capping for a lower second premolar. And here is a 3-year recall for direct bulb capping. Tooth was completely asymptomatic. We did also root canal treatment. After 2 years, we got complete healing. Direct bulb capping for upper first molar. And here is a 3-year recall. There is a barrier was formed in this area. Even in the anterior teeth, in the static zone, we can do direct bulb capping. Here is a tiny exposure, capped with the body, immediate post restoration, immediate post X-ray. As you can see, the body is highly radiopaque. You can easily detect the material in the radiograph. In this case also, I did direct bulb capping. This is a 1-year recall. There is slight narrowing in the bulb chamber, indicating barrier formation. And this is a 1-year recall clinical image. There is no discoloration occurred in the central. This is another trauma case. We did complete bulbotomy, and here is the immediate post bulbotomy. Even in cases with external cervical resorption, I did complete bulbotomy. This is a male colleague. We did complete bulbotomy, and this is after 1 month. There is a nice tissue healing, and the tooth was completely asymptomatic. This is another trauma case, came like this. After 6 hours of trauma, I did complete bulbotomy. If you can see, there is immature apex in both roots. And this is a 10-month recall, shows complete maturation of both centrals. And this is a 10-month recall clinical image. There is no discoloration occurred, so you are free to use this material in the aesthetic zone with no fear of discoloration, unlike most MTA brands causes massive discoloration. Even white MTA brands causes massive discoloration. Here we did direct bulb capping for lower second molar. Here is a 3-year recall showing barrier formation. Red arrow pointing at the barrier. Look at the difference. The barrier was formed. This is immediate post direct bulb capping. This is the X-ray on the left is 1.5, and the X-ray on the right is 4-year recall, shows barrier formation. The tooth was completely asymptomatic. Okay. This is a 50-year-old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be your treatment plan here, knowing that the first molar was completely asymptomatic? هتعملوا ايه في الحالة دي؟ روت كانال؟ على طول. تعمل ايه؟ لو خدت بالك هنا الديستال، شايفة الديستال bulb هنا طالع ازاي؟ Okay. I did root canal treatment to the lower second molar as the bulb was inflamed and has to be removed. Dark red diffuse bleeding. I cannot control the bleeding. If I could control the bleeding, I would do vital bulb therapy, maybe complete bulbotomy, but I couldn't. So I did root canal treatment. But I was able to do direct bulb capping in the first molar as the bulb was healthy and could be kept alive. So I did direct bulb capping. Here is after 1 year. Here is after 2 years. Barrier was formed. Look at the barrier here. Here it is. Again, please. خلي السؤال في الآخر ممكن؟ ماشي. في الآخر. This is a barrier formed after 2 years. Direct bulb capping for upper first premolar. Partial bulbotomy for lower first premolar. And here is the 1-year recall. Shows narrowing in the bulb chamber indicating barrier formation. Tooth was completely asymptomatic. Radiograph is normal. Complete bulbotomy for upper second premolar. Partial bulbotomy for upper first molar. Partial bulbotomy for upper first molar. Partial bulbotomy for lower second molar. It's a repeatable procedure. Partial bulbotomy for lower second molar. Even in cases with bulb polyp, this is a bulb polyp. I did partial bulbotomy. The patient reported completely asymptomatic. Partial bulbotomy for lower first molar. This is a non-bleeding exposure, so I have to enlarge the exposure site to a partial or complete bulbotomy site. Within the partial, I was able to control the bleeding, check the attachment, put my body material, and here is the immediate post restoration. Complete bulbotomy for upper first molar. Even in deep caries, this is a very deep caries, I did partial bulbotomy. Here is the immediate post restoration. Even in fractured cusps, this is a fractured mesolingual cusp due to the amalgam restoration. I was able to build the margin, and here is I did complete bulbotomy, immediate post X-ray, and here is the one you recall the patient was completely asymptomatic. Starting from this case, the diagnosis is irreversible bulbitis. Diagnosis was irreversible bulbitis, symptomatic irreversible bulbitis. Dark red diffuse bleeding came out upon accessing the tooth. After I removed the whole coronal bulb tissue and checked the attachment, I got hemostasis. I did complete bulbotomy. Again, case diagnosed with irreversible bulbitis. I did complete bulbotomy. Complete bulbotomy. Diagnosed with irreversible bulbitis. Deep bulbotomy in the distal root. Even in cases with bulb stone, this is a detached bulb stone. After I removed it, I found the bulb was healthy. I can control the bleeding. I did complete bulbotomy. Here is the immediate post X-ray. Here I did partial bulbotomy. Despite the diagnosis was irreversible bulbitis, I did partial bulbotomy. And the patient reported after 2 days completely asymptomatic. Complete bulbotomy for upper first premolar. Okay. Root canal treatment and vital bulb therapy in the same tooth. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? You can? ماشي. هنشوف. ما ينفعش canal. Root كامل. Whole root. Yes. We deal with a system, not just a hollow canal. Okay? This is a 9-year-old boy who came complaining severe pain that awakes related to his lower first molar. Upon taking a radiograph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. Upon exposure, dark red profuse bleeding came out with little amount of pus. Pus came out. Here is after accessing the tooth. Dark red profuse bleeding came out. Here is after trials to control the bleeding. I want to see where the blood comes from. This image told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I kept the distal bulb while I did root canal treatment to the mesial root. Here's a confit X-ray, immediate post-obturation and capping uses a concealer and putty. The X-ray on the left is 18 days recall. The X-ray on the right after stainless steel crown placement is 30 days recall. The boy was completely asymptomatic. And here is the clinical research that supports the procedure. Procedure مش haphazard. ليه research. Combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. Here is the 14 months recall shows complete maturation of the distal root. This means that the distal bulb stayed alive and continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Okay, here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious exposure. Retrospective study. Success of direct bulb capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during carious tissue removal. 1 year follow-up with the randomized controlled trial for Journal of Endodontics 2019. Conclusion, teeth with carious bulb exposures and reversible bulbitis can be treated successfully with direct bulb capping. MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and meta-analysis, Journal of Endodontics 2015. Direct bulb capping with calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less bulbal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, a novel bulb capping agent. The pre-mixed bioceramic material possesses favorable results and all the properties comparable to the currently recommended material for bulb capping MTA. The results are comparable or even superior. Bulbotomy of symptomatic permanent teeth with carious exposure using mineral trioxide aggregate. Bulbotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Success of coronal bulbotomy in permanent teeth with irreversible bulbites. An evidence-based review. Coronal bulbotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients in teeth with irreversible bulbites as a substitute to root canal therapy. Again, vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbites. Reports with long-term controls. Vital bulb therapy with partial or total bulbotomies using bioceramics under aseptic conditions is a viable treatment that will have long-term success in permanent teeth with irreversible bulbites when indicated correctly. Last study, vital bulb therapy for permanent teeth with diagnosis of irreversible bulbites, a biological basis and outcome from a bulb biology perspective and based from data from clinical trials. Partial and full bulbotomy using calcium silicate cements are successful treatment modalities for teeth with carious bulb exposure and symptoms of irreversible bulbites. Remember, the best root canal treatment is the one you can avoid, and the best obturation material is what God's created, which is the dental bulb. We'll root PT as a root canal filling material, and you can also use the butty as a root canal filling material. In this case, I filled the whole distal root in the lower second molar using the butty. I did this case 6 years ago. 2 years after, the patient came complaining severe pain related to the tooth. After I took a radiograph, I found a radiolucency under the distal root only, so I retreated the distal root only, where I filled the whole distal root using the butty. And here is the clinical research that supports the procedure. Selective root retreatment, a novel approach. 2 days after, the patient reported completely asymptomatic. Here also I did selective root retreatment. This is a female colleague, came complaining of the for lower first molar. Despite there is an extruded gataperca, I did selective root retreatment. I filled the whole distal root using the butty material. And this is 1 month recall, shows significant reduction in radiolucency size. This is a trauma case for upper central incisor where I filled the whole root canal system using the butty material. Again, another trauma case where I filled the whole root canal system using the butty. This is a heavily traumatized upper central incisor. I did apical plug using the butty. Then I put 2 fiber posts to build the tooth. This is an overextended gataperca. After I removed, I did apical plug using the butty. Here I filled the whole root canal system in the mesial and distal root using also the butty. Hydraulics power. Bioceramics are a real savior and a game changer material. How? Perforation repair. This is a case of upper first molar with large perforation where I repaired using the butty, and here is the 5 months recall shows healing. Here is another perforation case I did 6 years ago. Despite I could repair this perforation using composite, but I chose the butty because I can recall the patient to see the material. The butty still exists after 4 years, despite the composite at the distal margin was ditched. As you can see, the composite here was good. Here, the composite got ditched, and the butty still exists, did not washed out, did not resorb, which is a very tough test for any bioceramic material to survive such tough circumstances. The butty can be easily washed out by the oral cavity environment. Here, a referred case from a colleague for the inability to find the mesiobuccal canal. Here is a perforation site periphery after removal of the granulation tissue. After detection of the mesiobuccal canal, and here is the immediate post-obturation. and repair using both the sealer and the body. And here is the 1.5-year recall shows healing, and the sealer still exists, did not resorb, did not washed out. External root resorption. This is a female colleague who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a massive radiolucency related to a massive external root resorption related to the distal root. We decided to give the tooth one more chance, so we decided to do retreatment. Here is a large H file in the resorptive defect. It's a huge resorptive defect. I decided to obturate the mesial root first, so I blocked the distal orifice using Teflon because the canal were oozing blood, and I obturated the mesial root first. Then I did the same. I did obturated the distal root using the sealer, and here is the extruded sealer. This is the 4 months recall, shows significant reduction in radiolucency size. 8 months recall shows more healing, and the sealer still exists, did not washed out, did not resorb. And here is a conclusion from a study that was comparing different BC sealers worldwide. They found that root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the set surface. Day 0, 4 months recall, 8 months recall, and here is the 2-year recall, shows complete healing, and the sealer still exists, did not washed out, did not resorb. Intentional replantation and the crack management. I did this case, I did direct bulb capping using Dical in 2013. In 2017, apical periodontitis started to appear. We did root canal treatment. In 2019, the tooth almost completely healed. Unfortunately, in 2021, a horizontal crack pattern started to appear. We decided to give the tooth one more chance. Here is the methylene blue dye cracking, staining the crack site. I removed the cataperca and I filled the whole root canal system using the body. Unfortunately, the patient still have symptoms, so I extracted the tooth, cut the apical part of both roots, then put back again into the socket, and here is a 3 months recall, shows significant reduction in radiolucency size, and the patient became completely asymptomatic. Another intentional replantation case, referred from a colleague to manage a separated file in a dilacerated mesolingual canal of lower second molar. Unfortunately, I wasn't able to neither bypass nor retrieve the separated instrument, so I decided to extract the tooth, cut the apical part of both roots, fill it with the body, then put back again into the socket, and here is the immediate post intentional replantation. Deep split management for non-microscopic clinician. Here is a case of upper second premolar with Vertucci type 7. Vertucci type 7 has the anatomy of 1, 2, 1, 2. So I'm going to tell you some tips and tricks to manage such anatomy. Number 1, stick to the reference point, buccal cusp, palatal cusp. Number 2, recurve your instruments, your hand files, your rotary files. Number 3, shape both canals together. And what I mean by shaping both canals together, when you start shaping the buccal canal using, for instance, 2004, you do the same for the palatal. 2504 for the buccal, 2504 for the palatal, 3004 for the buccal, 3004 for the palatal. Because if you shaped one canal to the master apical file, every time you put the file to start shaping the other canal, the file will tend to enter to the larger one. So you find difficulty to shape the other canal, the narrow one. So that's what I meant by shaping both canals together. And of course, sonic activation and polymer needles for irrigation and disinfection is our main here. Metal tips may be difficult and maybe got separated. And of course, hydraulic condensation, inject your sealer, insert your getaperca cones, and you're done. Another Vertucci type 7, upper first premolar. Again, another Vertucci type 7, 1, 2, 1, 2. Here is another type of splitting buccal and lingual canals with nice microanatomy. Lateral canal here. Here's another splitting buccal and lingual canals. This is a difficult splitting in the lower premolars done with the naked eye. This is no microscope in here. So what we're going to do to manage such splitting, if you can see from the preoperative radiograph, there is one main canal and two tiny splits are obvious in the preoperative radiograph. I'm scouting the canal. I put my file, take an X-ray. Another file, take an X-ray, and see. This is just one split was detected, one split and the main canal. Here are the two splits were detected. I cannot see, I cannot fully shape these splits. Now, how I will obturate these tiny splits? I cannot see them. I cannot fully shape. I tried to make Getaberka harder. How? I pre-curve it, put an icy cube, and spray it with an endo ice to make it more stiff, so I can introduce these Getaberka cones in the splits, but I failed. I couldn't do this. So I decided to depend on another strategy, which is the hydraulics power. How? I chose the largest Getaberka cone that gives me the toughest tuckback. This Getaberka cone here was 4506. 4506 Getaberka cone. Then I down back till the level of the split. So I blocked the main canal first. I blocked the main canal first. After that, I injected the sealer and added the rest of the cone. As you can see, the sealer started to enter to the tiny split. There's no way else the sealer can go. So it enters the tiny split, plus a lateral canal started to appear. After that, I added more sealer and more tapered auxiliaries, seared off the Getaberka at the orifice level and do some coronal compaction. And here I got a heavily filled and buffed splits with the sealer. So I depended on the hydraulics power of the sealer. This is another level of splitting in the lower second premolar. After scouting, I got 3 splits detected. Here is a master apical file. Unfortunately, I separated one of the files in one of the splits. I tried to bypass. I couldn't fully bypass, but I tried some. It was a very tough bypass, by the way. And here is a confit X-ray. After I injected the sealer can easily penetrate beyond the separated file. And here is a middle post obturation for both the lower first and second premolar. This is another splitting for lower second premolar. And here is a nice internal anatomy with the sealer, different X-ray view. I just have one more case. I'm sorry. Okay. This is okay. This is a lower first premolar that was a part of a bridge with multiple splits. During a scouting trial, I put my file and I take an X-ray. 2 splits were detected, 3 splits were detected, 4 splits were detected. Here is a master apical file for the splits. Here is a confit X-ray, and here is immediate post-obturation using the sealer and the Getaberka cones. And here is a quote from my mentor, Dr. Alan Nasser: "If you're always worried about failure, you will never reach out for success." Thank you so much, ladies and gentlemen. I hope you enjoyed the presentation. Any questions are more than welcome. Thank you. قولي أسئلتك.
Any question?
Thank you.
Any question?
تتكسفيش. فوت تكتبي بقى المرة الجاية.
Doctor. In some cases, why you don't use lentul spiral to inject the sealer? It's easier.
Again, please.
If you can use lentul spiral in the case of the sealer, you can inject the lateral canals. You can make sure.
Old fashioned.
But it's doable.
Why do this? The sealer can easily
Easier.
flow.
It's flowable, but you can make sure 100% sure that it will flow into the lateral canals.
I can tell you a safer tip. What are you using for activation? sonic activation will be more efficient and more safe. The tool spiral can be easily get broken. If it's stuck, if it's stuck, it's frequently got separated. With the sonic activation, if you want more power for the sealer, just activate using sonic activation. Any device. It will make the sealer move and flow more. When you put your master cone fit to your preparation, for instance, 3004, and use the same size of the gatabersha will push the sealer. It's very fit. If there is another, if a room or a space besides the gataberka cone, put more tapered auxiliaries, not taper 2, taper 4 mainly. As much as deep as you can, sear off the gataberka below the orifice level and do some coronal compaction, and you're done. It's easy. The tool spiral maybe not common in our country, in my country. Plus, it's old. Maybe. Okay. كل ده مع السنجل كون. بس لما يبقى عندك مساحه ما تحطش سنجل كون. يعني لما يبقى عندك الكنال واسعه حطش كون وحيد. حط اوكسيلاريز، تيبرد اوكسيلاريز.
طب حضرتك عرضت حاله كان فيها بلب بليب.
مالها؟
طب ما في باثولوجيكال تشينج في البلب.
انا طالما عندي الكرايتيريا متوفره مش مشكله. شلت الجزء من البلب تيشو، عندي بليدنج، البليدنج وقف، وعملت حاجه اسمها تشيك اتاتشمنت. تمسك الدي جي 16 بتاعك وتحاول انك تزق او تبعد البلب تيشو عن الكنال وول، ستيل انتكت، خلاص انا هعمل فيتال بلب ثيرابي. مش خايف من حاجه، ولا السن ولا اي حاجه. ولو بلب ستون هعمل فيتال بلب ثيرابي، ما عنديش مشكله.
في ديفرنس بين الماتيريال فيتال بلب ثيرابي اند ماتيريال اوف روت كانال.
السيرنج ده السيلر اللي بنستخدمه، وده تستخدمه في الفيتال بلب ثيرابي برضه مفيش مشكله. لو هتقدر تكنترول الفلوابيلتي مفيش مشكله، استخدمه.
جلاس ايمر نحطه جلاس ايمر.
حط جلاس ايمر فوقيه. احنا بس بنخاف من وانت بتعمل اتش هتعمل رينز، فالرينز ده بالميه هيشيل البطي او السيلر، فاحنا عايزين حاجه تبروتكت الماتيريال بتاعتنا يعني.
طب
وبعد كده لو عايز تشيله شيله مش مشكله.
بره السؤال تاني، في ماده اسمها بالبوتيك، حضرتك عارفها طبعا.
عارفها طبعا، حبيبتنا في مصر يعني.
بالظبط. بسأل هل في ديفرنس مثلا في الريزلت ولا؟
هيوج ديفرنس، زي الفرق بين السماء والارض كده.
دي بتعمل كالسيفيكيشن في الكنال.
للاسف.
وهل هي كارسوجينيك؟
ما ينفعش تتباع في البلد اللي بتصنعها. ده كفايه. يعني هو سويس برودكت، خلينا نتكلم كده يعني، ما ينفعش تتباع في سويسرلاند، نو واي، ممنوع. لكن يتباع يجي في بلادنا يعني. اتفضلي. تكسفيش.
اوكي دكتور، بالنسبه للكيس الكومبايند اوف فيتال بلب ثيرابي
root canal,
how we can know the defective canals exactly, like whether
how can you again please?
How we can know like which canal is defective and which canal we can do the vital pulp therapy?
زي ما قلت لك عندك كرايتيريا، في بليدنج وقفتيه، الميزيال بالب ما وقفش، الميزيال روت ما وقفش، مش راضي يوقف البليدنج، هتوقفيه بالعافيه ما مش هيوقف. في انفلاميشن من الراديكولار بالب فلازم هتشيليه، فهتعملي روت كانال هنا. بس احنا بنتعامل مع روت مش مع كانال واحده، يعني بتعامل مع روت كانال سيستم، مش جاست الميزيو باكل فاسيب الميزيو لينجوال او اعمل الميزيو لينجوال واسيب الميزيو باكل. بعمل روت سيستم، روت كامل، واسيب التاني لو انا شايفه هيلثي اطبق عليه. بس تختاري الحاله، يعني ايه؟ يعني مثلا يبقى عندك حاله اوبن ايبكس زي كده، فورثت انك تعملي حاجه زي كده. لكن الايبكس اوريدي فولي ماتيور وهي في جزء منها مثلا يحتاج يتعمل له روت كانال، هعمل الحاله كلها روت كانال بس. فحطي الحاجه في مكانها يعني بس.
Thank you, Takamina.
Thank you.